And we are live today with MedTech Insights. I'm Jennifer Jose, and this is
Hi,
Ami
I'm
Bhatt.
Dr. Ami Bhatt. Nice to see you guys. Excited to be towards the end of February. A little sad that it's the end of Heart Month, but we have one more set of guests where we can talk cardiology today before maybe we change direction. So excited for today's chat. To all of you in Texas, talking to some friends out there this morning, sounds like recovery at least is starting, but it's going to be a long road. So thinking of you guys and hoping that maybe we can have a little fun over the next half hour if people are having breakfast or lunch out there, depending on where you are, and talk some digital health.
Definitely. So we have two more cardiologists that we're bringing on as guests for Heart Health Month. And Ami, I was wondering if you could share a little bit about your involvement in the American College of Cardiology and the AHA and the importance of Heart Health Month.
Absolutely. So as we come to the close of February as Heart Month, heart attacks are number one killer of many different groups in this country. And we spent a lot of time in the past few weeks talking about awareness, talking about how we can make sure that we take care of ourselves, and talking with a lot of people who are now looking at women's heart health, different ways to be able to monitor women and include them in trials. And also just thinking about the digital health landscape in general, digital stethoscopes, how we're getting get out there in the community. COVID has changed a lot for us when it comes to telemedicine and digital health. We know that patients weren't coming into care because they were worried about COVID, and now they are coming back, but there's still a lot of need to reach out into the community, a lot of need for access. And what we've learned is telemedicine and digital health can really accomplish that. So the American College of Cardiology and the American Heart Association have both worked very hard, along with the American Telemedicine Association, to say, how can we make this last into the future? And I think as part of that, the ACC's innovation section, as well as some very good companies led by cardiologists out there, are really tackling that problem. We would like to see you get your care at home, where you really live in your community. We would like to see businesses be able to work with cardiologists to help us get out to these patients. And so this is going to be an exciting day today where we get to talk a little bit more about it.
Yes, and as we promised, we're focused on digital health, new and innovative companies, and also healthcare leaders and innovation. So, two guests we have. One is Dr. Regina Druz, and one is Dr. Jeff Wessler. And Ami, I think you've worked with both Regina and Jeff for a while. Love to hear your stories and why we've chosen them.
Absolutely. So, when you think about women who are current powerhouses in digital health and cardiology, Regina Druz is the first person on many people's lips. She has been one of the people who said, hey, we need innovation in cardiology before innovation was a buzzword. And has been dedicated to digital therapeutics and really uses real world evidence. She's still a practicing cardiologist and uses real world evidence to then say, what is the next step and what do we need to do? So I can't think of anybody better to talk about that. Jeff is also a practicing cardiologist in New York City. And he was one of those people that said, gee, none of these systems are working for me right now. I want to reach my patients at home, but I'm not able to. And so he built a phenomenal team, and we'll hear about Heartbeat Health, his company, of which he's the CEO and the platform, but really said, you know what, let's take this in our own hands. As cardiologists, we know what we need. As physicians, we know what we need. Let's go out there and just build it for ourselves rather than waiting for others to do it for us. So I think it's going to be great to bring them on.
Yeah, very honored and pleased that they have agreed to join us. So with that said, we're going to bring out Dr. Regina Druz. She is the Director of Integrative Cardiology, SFH, the Chair of the American College of Cardiology Healthcare Innovation Section. She is dedicated to digital therapeutics and real-world evidence to change practice. Welcome, Regina.
Thank you, Jennifer, and thank you, Ami, for your kind words. I'm chuckling because I don't usually consider myself a powerhouse of anything. No, I'm just grateful to be able to get through the day while wearing multiple hats. But I think we have such a great opportunity right now in cardiology, and it's sort of been building over time, obviously. But we finally are in the arena or in the time frame where there is a lot of synergy between patients and physicians and also non-physician providers in regard to using digital health. And I have to tell you that it's very gratifying for me in my practice model to actually see that this is happening. And this is something that we're trying to expand on the level of the American College of Cardiology for our members, of course, to really bring them into the fold and to understand the value of the digital health tools through all verticals, whether it's wearables or apps or telemedicine, and really understand how to position these for the most effective clinical and pragmatic use. And that's kind of where we are.
That's fantastic. So when we think about you and what your vision is for the ACC kind of innovation section, COVID helped, oddly enough, a little bit, right? Helped push everything, and that's what we talk about a lot. What do you see as the biggest points that we need to focus on as a community, not just as physicians, but as you mentioned, every vertical, the companies out there that are working on wearables, on platforms, the venture capitalists who are thinking about investing or the private equity. What are the one or two specific areas where you say, if we all concentrate here, then we're going to be able to have telemedicine, digital health, and cardiology that's here to stay?
So, Ami, great question, actually. And, I'm a very diligent student in terms of innovation and business strategy. And what I think we need at the level of the ACC is the commitment to the value innovation as a concept, right? So what happened with telemedicine is essentially it catapulted itself right across that adoption chasm or gap from the early adopters to early majority, whether they were prepared or not. And I think our goal should be to really frame it within the value innovation framework. How does telemedicine provide, or digital health, affiliated digital health tools provides value to physicians and non-physician practitioners and to patients at a cost that seems to be reasonable? And where is that differential value, right? We found in quite a few interactions, myself included, that while telemedicine was exploding and the video part of it specifically was coming very fast into use during the pandemic, especially here in New York, we had numbers that were escalating rapidly and the shutdowns were very precipitous. The low tech approach was actually the most effective, and that was a phone. And so, we are going to then, I think, need to understand how to frame the value innovation concept for the digital health. There are a lot of options, as you said. There are multiple companies, multiple solutions. Some appear to be more design focused, some are not, different areas or touch points or the pain points that they're solving. But we have to, I think, be the stewards of this movement, right? Because at the end of the day, no matter whether we do a telemedicine visit or face-to-face, we're still patient advocates and we're advocates for our profession.
You could not have said that better. So a question, and powerhouse is the right word, right? Because there's the third rail of cost in telemedicine, and you went straight there. You were like, here, let me go there. Cost. This is a huge issue, right?
Right.
How are we going to do this? How are we going to measure it? Are we going to randomize people to in-person or telemedicine? Is that reasonable? How are we going to know when we do cost effectiveness studies that we've made a difference? I realize it's a very large question that could take us a week to answer, but your thoughts?
Well, it depends on what cost actually you're referring to, right? Because you could focus just on the reimbursement angle. That pandemic gave us some flexibility and opportunity to expand, of course. You can also focus on the opportunity cost because there were patients who did not do well despite the telemedicine availability in all forms. I'm referring to telemedicine in general, synchronous, asynchronous apps, phones, what have you. And those patients had actually an adverse outcome. I had a patient who passed away. I was a second opinion for this patient. He had 2 telemedicine visits, not with me. He did not want to have any more telemedicine visits, ended up having a massive heart attack at his home and passed away. So where is that inflection point? And the cost has to figure out not just the cost of changing human behavior, but the opportunity cost that arises from these negative consequences, right? So this is where I think makes it so complex, because this is not just about reimbursement. This is about what might be missing in the continuum of care if you are to, for example, stay at 20 or 30% of your visits being in some sort of a digital or remote format, whether it's audio, video, or audio only, or asynchronous evaluation.
It's interesting you say a student of this, but you're describing thinking about patient safety, human-centered design, economics, and then behavioral economics, and putting all of those things together to make us succeed, right? But it's great that you have that eye. Jennifer, questions for Regina? And I see some great comments out there. You've got a fan club out there, Dr. Druz.
Oh my God. Well, and I haven't even gotten to my VUCA concept. Well, maybe for the next show.
So I've known Regina for a while. Really, you've been one of the early advocates, really driving home the value of digital health. I'd love to hear what you saw with digital health before COVID, and then what you saw as the major transition point, especially for cardiology, and then where you think we're going as we kind of move out of COVID.
So, great question, Jennifer. And I think one of the things that was striking to me during the COVID pandemic is that we sort of assume that all we have to do is turn the video on and onboard the patients and teach the doctors how to log in and drop the bill. And then we realized that it's none of the above, because the telemedicine visits were not a substitute for in-person care. And this is probably a realization that, to me, honestly, it was new. I did approximately 10% of my telemedicine visits prior to the pandemic over video, but those were usually follow-up care. I had interaction with these patients face-to-face. So it was a supplement to my care. It wasn't a replacement. So I think what we learned is that they're actually not going to be a replacement. We will have to create some sort of a hybrid, self-sustaining ecosystem, and maybe telemedicine will be one of the solutions. Maybe there will be a digital front door of some type. We will have to learn how to safely triage our efforts and how to get, and again, we're coming to value and cost, the most value from this approach. Where will we meet our users? Understanding that we will need to phenotype those users too. They're all different. Some of them sharing characteristics and some of them are not. And so I think this is the challenge in the post-pandemic era, or nearly post-pandemic era. There really isn't an acute emergency anymore, but there is a need. And so now we need to understand what is that need and how do we relieve the pain, and do it in a way that is sustainable as well, right? Because if tomorrow CMS and CMA Verma decides that Medicare shouldn't be paying again and should be again having the site restrictions or what have you, do we then pull back? We can't afford to do this. We as cardiologists, and I think any physicians, we are there to guide our patients first and foremost. And it is through our experiences and our leadership that the profession and even the government will take action. And this is where we need to place ourselves.
Magnificent. I think that's exactly right. That's exactly right. So with that in mind, actually, why don't we bring in our second guest as well? We have Dr. Jeff Wessler, who's with us today. He's a cardiologist and the founder and CEO of Heart.Health. Jeff's also an assistant professor at Columbia University and has been dedicated to bringing virtual care into the cardiovascular space for a long time, and finally broke out and did just what Dr. Druz said. He said, we need to be a steward of this process. And so he is one of the stewards of this process. So do we get to clap for Jeff? Is that it? Excellent. Oh, you're muted, Jen.
And we have Jeff. That's all I said. That was an exciting comment. My insights of Jeff Wessler and his decision to found a company before telehealth became the massive thing that it is. So very excited to have you here, Jeff.
Great, thank you. Well, yeah, thank you, Ami and Jen. So nice to be here and to join Regina on this. I think this is such an exciting space and a time for this space right now. I like to say we were doing telecardiology and virtual care before it became cool, but it became cool really quite rapidly this past year, and it's been amazingly exciting just to see how this field has evolved and where we're going.
So tell us a little bit then, Jeff, about Heartbeat Health, because I'm going to challenge you a little bit straight from the beginning. There are a lot of people out there who have platforms and who say, we're going to help you get out to the public. We're going to help you deliver care. And some do it in a way that the doctor doesn't know the patient. Others do it in a way that the doctor's established with the patient. What is it about Heartbeat Health? When you decided to do this, what's different? What sets you apart from other platforms?
Yeah, it's a good question, and you're right. There are thousands now of telemedicine platforms out there, different aspects of different facets of the virtual care environment. And I think finding the niche in the area where you can really focus in to actually prove out value, that's what we feel is going to be that differentiator for us. And for Heartbeat, we really came out and said, well, we have a few core principles that are going to guide how we create, develop, and build a product and ultimately a company. And one of them is that we will be provider first, and we'll really take the approach that we will take all of these tools from the telemedicine and the remote patient monitoring and the disease management tools, but we'll apply them to how do we get the cardiologists and the cardiovascular clinicians to do better care. So, I think that's differentiated in that it is not a patient engagement app or a patient engagement tool whose primary job is to engage that patient, but rather we've flipped that and said our primary job is to assist and help that provider and clinician team do a better job of care. And then I think the second aspect of how we've differentiated ourselves is really, to Regina's point, taking the stance that we need to bring an evidence-based and data into this field if we're going to prove any long-term value. I think by all accounts, the COVID digital health bump has seen a lot of companies and businesses grow, but not really create sustained long-term models. And the way to protect against the future, the years to come, as pandemic digital health goes down, is really to prove and demonstrate through data and evidence that the actual intervention is providing value.
That's great. So one of the conversations that I think you and I have had in the past is we, as cardiologists, many of us, in fact, Dr. Druz has said this too, we lament the fact that we have so many guidelines, but at the same time, if you look at guideline-directed medical therapy for basic things like atherosclerotic cardiovascular disease or heart failure or even atrial fibrillation management, we're not at 100% among very good cardiologists in this country. It is hard to keep up. It is hard to make sure that every patient is caught, brought in, and on the right thing. Have you thought about that in the platform? I know this was a conversation we had a while back, so we'd love to get an update on, is that something that you are doing? And then maybe once you answer that, Dr. Druz, I'd love to hear from you in terms of, does that count as value? So Jeff, maybe first to you about incorporating that.
Yeah, sure. So I think it's such an important part of the digital care landscape. And I think there's two phases to this. The first phase is, how do you translate those guidelines, which live on PDF, hundreds of pages of PDFs, across computer screens and academic libraries all over the place. How do you translate those?
Cardiologists, you guys have a lot.
We have an unreasonable amount.
There are so many guidelines for. Okay, yeah. I'm the only non-cardiologist here, but I trained in internal medicine originally, and then nephrology. But cardiologists, you just are over the top. Go ahead. Sorry.
Yes. No, so you're right. We have far too many guidelines for any individual practitioner to be able to stay up to date, interpret, and then get those into practice. So the first phase of this is make them interpretable, get them into a format where, in a smart way, you populate the relevant and appropriate guidelines for a given patient or a given case at the right time. And so that's phase one for us, is get those guidelines in an interpretable format in front of the clinician. And then phase two is actually to give them a process to implement that care or the guideline without having to actually go out and spend the resources, energy, and time to do that. And so that's our roadmap for digital guidelines, and it's one that Heartbeat has developed intimately with the ACC because we're completely aligned in this regard.
That's fantastic. So, as Regina comes on to give her thoughts, I will say this needs a little cardiology shout out to people like Jeff Kuvin and Katie Berlacher and Janice Sibley, who are the heads of the innovation, the education section, who call this actionable knowledge. That they have coined that term, and we love it at the American College of Cardiology. Take that knowledge and make it something that we, standing in an office with 17 patients today, can actually use. And so this is great to hear. Dr. Druz, your thoughts about whether that counts as value and how we'd measure it?
Thank you, Ami. And, Jeff, this is fascinating. Is the knowledge itself at the point of care valuable, right? Most of us will agree that it is. But the problem that I think we see in cardiology, as Jennifer very aptly mentioned, we are swimming in the guidelines. And at a certain point, the information overload and the decision fatigue sets in, right? And I'm a big fan and a student of behavioral economics, having worked with some companies in the behavioral economics space, I find this concept itself fascinating. I feel that to really have a sustained competitive advantage, one has to overcome this information overload and decision fatigue. And so this is where I would like to see a product that doesn't spit out yet another set of rules for me to follow, because I'm already logged into my electronic medical record that wants me to do clinical decision support. So it will become overwhelming, I think, for clinicians to execute if you have to compile different systems and all they're doing is overloading you with information. So I think the challenge is really to overcome this hurdle, and whether it will be a ranking of some sorts, perhaps, the guidelines and the applicability of different things in the guidelines will not just go into class 1, 2, and 3 as we always do, but maybe it will match, if you will, a certain patient situation to the guideline scenarios and say, well, this is your 90% match or this is your 70% match, so that we as end users can actually overcome these behavioral hurdles. I like to design, so some of the things come off like this, but but certainly would be super helpful for us, because these guidelines actually they don't even change fast enough, because as literature is coming out, meetings are coming out, and there are a ton of new initiatives, especially in the digital health, with regard, for example, to digital therapeutics. It's like wild west out there. Like you can do almost anything and call it a digital therapeutic. I realized recently it doesn't even have to be prescribed. It could still be called digital therapeutic. So there are a lot of interesting angles here.
Oh, Dr. Drew, you're touching upon so many things right now. So a few things. One is, when we think about physician burnout, I think that's huge, right? The decision fatigue. I had the privilege of being on one paper, hopefully more someday, with Dr. Cass Sunstein, and we looked at type 1 and type 2 thinking, right? Fast and slow thinking, Daniel Kahneman. And the one thing that we've always said is, wouldn't it be great if a patient sitting in their, couch at home and us relaxing in our office and not running through a clinic could both be in that slow, methodical thinking, experiencing way of communicating? How great that would be. And so I feel like what you're setting up is going to be that. By the way, I'm sure that Dr. Wessler's team is watching right now and taking ample notes about the 90% match right now. Great suggestion. We have a couple questions that are coming in. So why don't we take those? And then I want you to tell us a little bit more about your interaction with the FDA and the NIH before we finish, though. So Dr. Pillai says, in a country like India, where data is really budget friendly, rural penetration of telehealth has not yet reached its true potential. With a recent study citing rural areas overtaking urban areas in coronary heart disease cases, I wanted to call it congenital heart disease, what would be the suggestions to improve rural lives? Any takers on that?
So I'll start and just say that I think, the rural urban mismatch has been a very important, but probably an underlooked opportunity for telehealth, especially this last year. I think as we saw, telehealth, and this applies particularly for cardiovascular disease, get out there, we actually saw an exacerbation of the access issues that are occurring in medicine across the country and across the world. And so what I see is that this needs to be a really intentional part of the delivery strategy for any virtual care intervention, and this goes beyond just cardiovascular disease. Is achieving health equity and making sure that access is obtained is going to across the different settings is going to require really a dedicated effort to make sure that every population in every different area has access to that intervention. So for me, the biggest answer to this is it really is going to take focus and dedicated resources to achieve this.
Yeah, this is where dedicated governmental alliance is also essential, because I think we're not the only ones. If you think about education in these remote areas as well, and access to the internet for here in the United States, Zoom teaching, right? But in India, even being able to get people more knowledge than what they have there in the rural areas. We're not alone in wanting better, mechanisms of communicating into the area, and we have to have governmental buy-in to be able to do that.
If I could even add into it, I agree with Jeff, but I think it's less a question of data and it's more a question of infrastructure. And a lot of rural areas, they suffer from bandwidth issues, right? So the full-blown video visits might be challenging. There are telemedicine companies out there who perfected the low bandwidth type of a situation, but for rural users to get adoption to telehealth, I would say think of what actually is telehealth for a rural user that has the most value. Maybe it's the phone, maybe it's a mobile app where they can self-report or do a chat message with a provider or a group of providers. So this is, again, comes down to how do you get value depending on who your users are.
I do think also, we have kind of microeconomics. We think about smaller areas, and we do that in a way with kind of micro health, right? In that we train the trainer. We go into a community, we teach one person to teach others. And I wonder if telemedicine, telehealth, digital is a way for us to even be better at educating people who are out there in those rural communities, Ashwin, when I kind of think about this. Because that still, I think, that human connection and trusting someone in your community is sometimes the best way for us to get health into these communities and healthful lifestyles and trust of what we're giving people. So, I wonder if that's really a place that we could do, is do a better train the trainer model, if you will, using this.
You got direct feedback from the audience. I mean,
there we go. Do you want to ask Eric's question next?
Sounds perfect. So we do have another question.
So Eric says, it seems with a number of cardiology guidelines, Jen, Eric's right on your bandwagon, cardiologists might appreciate this level of decision support if it simplifies their workflow. Oh, excellent question, Eric. Does this also
having to learn all your guidelines again?
I know, but we don't. Anyway, we'll get into that another day. Does this also impact indication billing codes and create contemporaneous notes?
So I'll just say quickly on this that this is such an important question. It actually highlights that there are two competing models in the way that virtual care is delivered here. It's the fee-for-service model and the value-based care. And I think what we've been talking about is the promise of virtual care to deliver on the value-based side, but the use that's taking place right now is on the fee-for-service side. And that from a digital health company perspective is a real challenge because you have to navigate that. And so our take on this has been that we have to provide the tools to be able to achieve the fee-for-service needs, make sure that there's a simple workflow, that it creates an audit trail for the billing codes and auto-populates all the documentation that's needed to support any of the remote or virtual care claims, but then use the longer-term data arc and the workflow to show that you can actually demonstrate cost savings at a value level. And navigating that trajectory between fee-for-service and value, I think that's what will win in the end.
Dr. Druz, I see that we're at 12:32 and people are maybe wrapping up lunch on the East Coast, but a question for you. As we think about interacting with the FDA, I know that you had some recent meetings with the NIH in your role. Will you tell us just a little bit about your thoughts about kind of where we're headed, some novel things I think that you'd learned recently about those sections, just that our audience might want to hear?
So absolutely, and I encourage the audience to take a look at the FDA Center for Digital Health Excellence, or Center of Excellence for Digital Health. I always mix up their name, but they're public, they're on the website. There's been a recent release of FDA guidelines as those apply, for example, to digital therapeutics, that are definitely a worthwhile read. There are a lot of regulatory updates, and I think it's really important for physicians. We're talking about cardiologists now, but it doesn't have to be only cardiologists, could be other physicians as well, to understand how FDA is conceptualizing the digital health as a value add, right? Because a lot of that value add will have to conform to regulatory guidelines. And so at least some familiarity is why FDA is considering a lot of digital health tools, low risk, class 1, class 2 devices, or software as a service type of a platforms would be really important. We have recently engaged with the NIH, actually NHLBI, on the part of the ACC Healthcare Innovation section, and we're going to have our first pitch showcase in April. So do look out for these announcements. You will see a range of companies, from digital health tools to actual biotechnology companies, some really cool stuff. They've been funded and they're coming out there to present their products and to form the bridges with the community of practitioners who are well aligned.
That's fantastic. So, it's so sad when we are at time. Maybe I'll give a couple closing thoughts, and would love to hear that from you as well. I have enjoyed today immensely. I knew that I was going to want this to go on for a couple more hours. There's so many areas that we haven't even touched upon, but it is exciting to see that there are people dedicated to thinking about the future of telemedicine, digital health, and not because we love telemedicine, digital health, which we do. This is where the clap should come in, but because we really we want patients to get the kind of access that they need in the areas where they live. We want them to be partners and understand their care, and that's why we do this. And that comes across so clearly when both of you speak. So this has been really exciting. In the future, we have a couple other people lined up moving forward. We will have some representatives from the FDA. Dr. Druz is going to put us in touch with some of the people from the NIH as well. And we'll be thinking a little bit also about the emergency room, about pediatrics, about wearables, and some of our larger companies out there who are providing at-home vital signs, so scales, blood pressure cuffs, other things, and have them with us as well, because we're going to need to partner with all of them in order to really make healthcare in the home happen. Dr. Druz, maybe some final thoughts first, then we'll go to Dr. Wessler. And of course, we always end with our host, Jennifer Joe.
Yes, well, exciting times. I learned a lot from Jeff and from both of you. Thank you for having me. And if I were to depart one message to our docs, is that be the stewards of digital health movement, shape it. It is fun and exciting, and you can learn a lot in the process.
Great. And I'll just wrap up and say thank you as well. I think this has been a wonderful session. I too learned a lot, and I think it's so important that we keep thinking about the next stage of digital health, and as we like to say, really protecting its future and making sure that it continues to add to the landscape of healthcare.
So I want to say a big thank you to our audience. Thank you for your questions. Thank you for watching and following. Thank you to our guests. This is MedTech Insights, coming to you every Tuesday at 12 noon Eastern Time. So I appreciate it, and see you next Tuesday.